get started just with a couple of quick announcements. So thanks everybody for joining us on yet another remote cardiovascular grand rounds. Next week we had a cancellation, but Liz worked her magic and we were very quickly able to work on getting a stress and resilience town hall set up. I think it should be a really nice follow-up to the group session that Matt Berg so artfully led several weeks ago. So I do hope everybody will join for that next week. It'll be led by Dr. Jacob Tebbs from the Department of Psychiatry. So it should be a terrific program and one that he's been doing for other sections as well. So I think it'll be a terrific way to bring the section together yet again and reflect a little bit on how this COVID pandemic has impacted us all, and hopefully also just help us all heal together and look forward to the new normal. So with that, I will pass the mic over to Joe Carr, who will introduce our esteemed speaker for today.
Thank you, Dan. Thank you. And it really is a pleasure to welcome back Dr. Ken Ellenbogen back to Yale, even though it's not in person this time around. He is a very dear friend and colleague, and someone who does not need any introduction. He did his undergraduate at Princeton University and his med school and residency at Johns Hopkins, and subsequently did his cardiology fellowship and electrophysiology at Duke. And following that, joined the Medical College of Virginia back in the late 80s, where he achieved a rank of full professor of medicine in 1997. He received an endowed chair in 2001, became the vice chairman of the Division of Cardiology in 2003, and was vice chairman in 2009. And following that has now been the chief of the Division of Cardiology at the Virginia Commonwealth University School of Medicine. And he also is the director of the cardiac electrophysiology program at MCV. Ken really, again, really needs no introduction in the field of cardiology and electrophysiology. He is on the editorial boards of multiple prestigious journals. He himself has published well over 250 original peer-reviewed articles, many book chapters, more than 150 book chapters, editorials, reviews, and is the co-editor of several major textbooks in cardiac electrophysiology and pacing, including the definitive textbook and the definitive reference in cardiac pacing and ICDs, which essentially is sort of our Bible when it comes to that one that we really use in the field. And we refer to it as the Ellenbogen textbook. He has been the chairman of the Heart Rhythm Society Board Review course. He is on multiple writing committees for the ACC and AHA and HRS guidelines. And back in 2015, he very appropriately won the Distinguished Teacher of the Teacher of the Year award from the Heart Rhythm Society. It is really unfortunate that he's not here in person, but it is really a pleasure and an honor to have him talk to us today about cardiac pacing of the conduction system in the heart, and look forward to the talk.
Thanks very much. It's going to be hard to live up to those accolades, but I will do my best. I was telling Joe before everyone joined that my wife was actually born in what later became Yale New Haven Hospital, but then was Grace New Haven Hospital. And we have some big ties to the community up there. So it really is a pleasure for me to talk about the true history of physiologic pacing. Here are my disclosures. We always think about pacing as a therapy to treat bradycardia. And this is a patient who presented with a Stokes-Adams attack. In fact, I suspect the original description of Stokes-Adams attacks with patients who had complete heart block or bradycardia was probably due to the polymorphic ventricular arrhythmias that they had associated with those arrhythmias. But what I'm going to talk about is the hemodynamic effect of pacing, which is something that goes back very, very far, and something we've been interested in on and off for the last 30 years. This is one of the earliest studies published in the 1960s and looked at a small number of patients. Here you can see the sample size in this study, a little bit over 30 patients, and you can see they measured cardiac output using a Swan catheter, using thermodilution dye methods, patients had complete heart block, to try to determine what the optimal heart rate was at rest. This is how simple and how basic the early hemodynamic studies were. This was followed by hemodynamic studies that looked at optimal heart rates with exercise. And then in the 1980s, the biggest thing in physiologic pacing, of course, was the importance of AV synchrony. Now, the importance of AV synchrony, if you actually go back and look at the original description of that, it actually goes back to the cardiovascular physiologist Carl Wiggers, one of the giants in the fields of cardiovascular physiology. And he created complete heart block in mammalian ventricles and looked at pulse pressure tracings and looked at when the AV was synchronous. Well, then you optimize the dPdt, you optimize stroke volume. And when the AVs were simultaneous, the dPdt went down, stroke volume went down, and likewise when they were the same. Clinically speaking, much of the 80s and 90s was focused on, and here's a pressure tracing showing the same thing in the lab, in the cardiac catheterization lab. This is actually a tracing made at Mass General Hospital almost 40 years ago, where they had an arterial pressure tracing and then VVI pacing in a patient had complete heart block. And you can see the hemodynamic augmentation, the augmentation in stroke volume when the P wave is positioned to fill the ventricle prior to ventricular pacing. Well, these observations led to an interest we had in not just understanding the hemodynamics, but also in understanding the autonomics. And the hemodynamics are intricately related to the autonomics. This was a study we did, published in JACC many years ago, where we measured sympathetic nerve activity. And I'll show you a little bit in the next slide about the setup we used. But we actually measured sympathetic nerve activity in patients that implanted dual chamber pacemakers. Then we measured their sympathetic nerve activity with VVI pacing at 60 beats a minute and DDD pacing at 60 beats a minute. And you see with dual chamber pacing, there is a significant decrease in sympathetic tone. Well, it turns out, at least in animals, if you measure sympathetic tone in the skin, or even measure sympathetic tone in the renal arteries, it is very, very similar to sympathetic tone going to the heart. So sympathetic tone measured everywhere or anywhere is fairly representative for the sympathetic tone to the heart. And this was a study we did. And this is a little bit of the get up here. You can see in the upper right-hand corner. The needles we use to record sympathetic nerve traffic are literally about the size of a hair, or 5 or 6 human hairs. Obviously, so they're very, very tiny. And of course, in order to pierce the skin, they have to be fairly sharp, but they are, in fact, much smaller than even a 27 gauge needle. And what we do is we have a needle on the outside of the skin, and we use that to deliver electric pulses to stimulate the muscle. And then using that, we can track sympathetic nerve recordings. This is a preamplifier. The patient's leg has to be placed comfortably. And in fact, we were able to even do tilt table testing on this. This is an example of a patient who has severe carotid sinus hypersensitivity. And you see the baseline electrocardiogram and the top tracing, arterial pressure tracing in the middle, and muscle sympathetic nerve activity on the bottom. In the control state, when you press on their carotid, You see the black line here. You see their arterial pressure goes down and their sympathetic nerve activity is inhibited. If you start pacing after you press on their carotid artery, sympathetic nerve traffic is decreased and their arterial pressure goes down. And again, you see control with carotid sinus stimulation. You have syncope, carotid sinus stimulation, and atrial pacing. After that, you have syncope with a big drop in blood pressure. But if you start pacing somebody before you give the stimulus to the carotid sinus, their blood pressure is maintained, sympathetic nerve traffic is higher, and they don't pass out. So autonomics are important in terms of the adaptation, the way humans adapt to pacing. And this is a model we have with ventricular pacing or VVI pacing. You have decrease in stroke volume that leads to decrease or inhibition of the baroreceptors, which goes to the brain. Retrograde VA conduction leads to increase in LA pressure, increase in pulmonary artery pressure, activation of the vagal cardiopulmonary mechanoreceptors that are in the posterior wall of the left atrium and the heart and lungs, and that leads to stimulation of the brain. And that can lead to bradycardia vasodilatation and a variety of events that can result in abnormal autonomics. So you see there's an impact of AV dyssynchrony on the autonomic nervous system, which results in poor adaptation of the heart to these changes in terms of changes to arterial baroreflexes and the vagal cardiopulmonary reflex. And then the next area of interest was the impact of heart rate on hemodynamics. And you can see here in two different patients. Here in this one patient, as the patient exercised, their cardiac output or stroke volume increased, then it plateaued at about 60 to 70 beats a minute. In the next patient, their cardiac output increased to 80 to 90 beats a minute. Then it had not much of a plateau. Then by 90 beats a minute, it decreased. So heart rate, AV synchrony, autonomics, all those things have profound impact on the hemodynamics of cardiac pacing. This was a study done in the late 1990s by Frits Pritsen and his group in the Netherlands. And these are pressure volume loops that they did by putting a catheter in the LV pressure, and were able to create pressure volume loops. And you can see in the purple is the baseline pressure volume loop in sinus rhythm. And then in blue is the pressure volume loop with ventricular pacing. What happens with ventricular pacing is you have a shift rightward that operates at so the LV operates at a larger volume under all loading conditions. And that at a given LV volume, LV pressure and stroke volume, LV pressure and stroke volume, and the work the heart does, which is the area inside the blue rectangle, is less than the work the heart does in sinus rhythm. So we have a lot of data from autonomics with AV dyssynchrony and impairment of baroreflexes. We have data from hemodynamics showing altered pressure volume loops. All that tended to indicate that ventricular pacing is bad. This is an animal study done in 2000, not only showing that ventricular pacing is bad, but even after a relatively short amount of time of ventricular pacing in this animal model of cardiomyopathy, that the ejection fraction went down about 15 points. Now you see the ejection fraction still normal, but it is substantially and significantly decreased after only at the beginning of ventricular pacing, and continues to decrease with ventricular pacing. And then when ventricular pacing is stopped and the animal undergoes atrial pacing, the ejection fraction goes back up. So ejection fraction goes back to baseline with atrial pacing, and there's really no significant change in ejection fraction with baseline. And that led to this sort of model, again, with ventricular pacing leads to reduced pump function, which leads to neurohormonal activation from the autonomics, discoordinated contraction of the ventricles, left ventricle, asymmetric hypertrophy, reduced coronary reserve, molecular changes, cellular changes that become enforced. Really, the first clinical observation that ventricular pacing may not have been good for patients actually is only about 17 years old. There's a study Mike Sweeney and I did from an NIH trial, really in patients who had six sinus syndrome, where patients who had six sinus syndrome were randomized to dual chamber pacing or VVI pacing. And these were the events rates by ventricular pacing during the first 30 days. And then you can see if ventricular pacing was greater than 40%, as you can see in this black line here, the non-solid line. The proportion of patients who were event-free went down significantly to about 82% versus 96%. And in terms of freedom, so there's a higher risk of heart failure, a higher incidence of AFib in these patients during long-term follow-up, suggesting that if you were being ventricularly paced more than 40%, that this was a disadvantage. And one way to prevent this or to change this was to do CRT pacing, which is pacing of both the right and left ventricle. And here you see in this study, you can see baseline, and at 1 week CRT is initiated, and you see an improvement in DPDT during CRT. That once CRT is discontinued, your DPDT comes down to baseline. So improvement in DPDT with CRT, and with CRT, you see a decrease in left ventricular volume that goes back when CRT is shut off. CRT is shut off, LV volume goes back to baseline. So there have been a number of studies of CRT. We know that with relationship to your QRS duration, if your QRS is about 140 milliseconds or longer, there's a benefit for CRT in terms of decreasing total mortality. And if we look at patients who have left ventricular reverse remodeling, defined as a decrease in LV end systolic volume, shown here, a change in LV end systolic volume at the end of 12 months. One sees, for example, percent of patients improved in the orange line is about 60 to 65%. And then when CRT is programmed off, you see about a 40 to 50% change in the LV end systolic volume index. And this therapy not only saves lives, is not only associated with ventricular remodeling, but is a very powerful therapy. CRTP costs about $10,000 per quality of adjusted life years in US dollars, and CRTD costs about $18,000. And that compares very favorably with other therapies we use, such as TAVR or TAVI, which is about $22,000. Even the prescription of Crestor, as it was used in the Jupiter study, costs more per quality of adjusted life. Here's LVAD to put that in perspective. Here's some of the drugs we use for colon cancer. Here's warfarin for non-valvular AF, $370,000 per quality of adjusted life years. But it's a therapy we don't think much of. Now, the problem with CRT therapy, or the Achilles heel, an area that we've always tried to do better in, is to better select patients for CRT therapy. And the bottom line is, dependent upon how you measure it, whether you measure it in mortality or heart failure hospitalization, or whether you measure it in changes to LV end systolic or end diastolic volume, or neurocard association, or some composite of both, there are about 20 to 40% of patients, depending upon the study, depending upon the time it was done, of patients who get this therapy who don't get any better. And so this is an area that I'm going to talk to you about. How can we do better? And it's interesting to me because I've thought about this and worked in this field for a while. I think the answer is we have to understand better the electrophysiology and the hemodynamics of the human heart. One of the most exciting papers to read is a paper written 50 years ago. You really have to look at it. But this was the paper from the Netherlands, published in Circulation in 1970, where they mapped the electrical excitation of the human heart. And here you can see this in the RV and the LV here. And what you can see here is early activation of the area where the his Purkinje system inserts here on the RV-LV septum, with late activation of the lateral wall, the left ventricle. The latest activation is up here in blue, about 65 or 70 milliseconds after QRS onset. And in the RV, over here in the RV lateral free wall, LV lateral free wall, here you see the septum, again with the early activation due to the his Purkinje system. So that's the activation, normal activation of the heart. This is a study studying the electrical activation in left bundle branch block, looking at electrical activation in patients who have typical left bundle branch block. Now, they didn't do this in the operating room, which Dirk Dürer did, by putting plunge electrodes in the human heart. Hard thing to do. This was done in human beings who were wearing a vest that had about 255 unipolar EKGs on the outside. And these patients all underwent CT scan to look at the positioning of the right and left ventricle in their chest. Then they wore this vest that had all these electrodes, and they were able, based on the inverse hypothesis, to understand how the heart activates during left bundle branch block. And guess what? The most amazing thing, the first take-home message is that it's not uniform. The activation of the left ventricle and left bundle branch block is not uniform. RV breakthrough is fairly stereotypical in the anterolateral wall. But during left bundle branch block, there could be 4 different patterns of conduction, of slow conduction in the left ventricle, from base to apex, with the lateral base typically last. There could be block anteroseptally. So what would happen? So electrical activation has to go way around here. Or there could be block anterolaterally. So electrical activation has to go around this way. Or posterolaterally or posteroseptal. And where there is block, determined how the left ventricle is activated. And so it makes sense that if you're going to pace the left ventricle in patients who have left bundle branch block, depending upon the pattern of block, you might need to put the pacing lead somewhere else. This is just the same data where we look at these beautiful color maps. And to orient you, this is the left ventricle, looking at it in the anterior projection, in the left lateral projection, and the posterior projection. And this is the timing of activation in 4 different patients of left bundle branch block. QRS duration shown here. QRS duration of 140, 180, 160, and 180 milliseconds. Use the LAD to orient you. Where there is a black line means that there is an area of complete conduction block. And this shows you that because you see the activation has to go around that area. Here you see it's activated relatively in brown at 45 milliseconds. Then activation goes around this way to get to the left ventricle. And in the next patient, it has to go way down this way and sort of back around here to get activated. And here, this patient's line of block, you only see it here. It's sort of base and lateral. So every patient has a different area of conduction block or extreme delay. And this tells you how the wavefront has to conduct. Now, if I show you the EKG on these patients, you'd say left bundle branch block, left bundle branch block, left bundle branch block, left bundle branch block, and you just say the QRS duration is different. But the take-home message is not left bundle branch block, but these patients have fundamentally different ways of activating the ventricle and areas of block. Now, this is another patient, and you might look at this EKG and you may say, is this left bundle branch block or is this an intraventricular conduction delay? Regardless of what you say, this is a patient who has a prolonged QRS duration. You can see this patient's QRS is at least 160 milliseconds. So this patient would probably get sent to the EP service and they get a CRT device, and you can see at baseline from this beautiful body surface mapping, there is really no real area of LV conduction delay except for the base of the heart. And we don't put LV leads near the base of the heart. And you see a broad area of conduction delay, not even very impressive. So this is a non-responder. It's not clear you can put the lead anywhere in this patient's left ventricle and still convert them from a non-responder to a non-responder. So this is a patient who has an eccentric activation, but abnormally slow activation with incomplete delayed conduction, but QRS duration 166 milliseconds, but not going to be a responder to CRT. Even in patients that our brain says they should respond to CRT, here's a sample patient like I showed you, and you say this is just typical textbook left bundle branch block delay where the lateral basal wall of the left ventricle is delayed. As you can see, blue is late conduction. But here's a patient who has 100% RV apical pacing, and they develop a cardiomyopathy. And here you see in this patient that they look very different from left bundle branch block, even though their EKG, their electrocardiogram with RV apical pacing, looks just like a patient has left bundle branch block. Here you see their RV apically paced here, so that area is early. The base of the RV is a little bit late. And here you see the lateral wall of the LV is a little bit late, but you can see it's very different from a patient with left bundle branch block. The area delay is quite different. So what is the solution to this problem of patients with different areas of delay and conduction? Well, one thing that's theoretically is that we need to be able to access all regions of the left ventricle, period. And to do that, you need to have endocardial pacing, LV endocardial pacing. What are the advantages? Well, the advantages are shown here. You have faster activation and more homogeneous, and you have transmural activation repolarization. Here's an example. Here's the Purkinje conduction system, and you see how rapidly conduction occurs in the Purkinje, through the Purkinje conduction system. Here's LV endocardial pacing, and you see you're conducting about 1 meter per second as opposed to 1.5 to 2 meters per second. But with epicardial conduction, conduction is fairly delayed. If you get faster and more homogeneous LV activation, you're going to get a greater mechanical response and less site-dependent mechanical response. So let's look at this. This is an elegant study done about a decade ago now between two medical centers, and they took 35 patients with non-ischemic dilated cardiomyopathy, and every one of these patients underwent LV endocardial and LV epicardial mapping. At the same time, they had a catheter placed in their LV to measure dPdt, and they had Doppler imaging, and then the LV pacing sites were assessed. systematically at different areas by measuring dPdt max, dPdt min, pulse pressure, and systolic pressure. And I'd like you to focus your attention on the percent change in dPdt max. If you find the best LV endocardial site, you have about a 32% improvement in dPdt max. If you find the best epicardial site, you only have about a 15% improvement in dPdt max. So the take-home message from this elegant study, all non-ischemics, all dilated, all left bundle branch block, was that you get about twice the bang for your buck in terms of dPdt max from the CS pacing. And the worst site of pacing, you get almost no improvement. So what does that mean? That means that this best site could be anywhere. And you see the wide distribution of best sites, and you see the wide distribution of worst sites. So there isn't not necessarily a priori a best site or worst site, either endocardially or epicardially. So this hypothesis was studied in the All-Sync trial, which was a European trial, a prospective multi-center study of LV endocardial pacing for CRT. And these were patients who failed CRT, either non-responders or patients who couldn't have CRT. And the take-home message is that if you took a non-responder to CRT via the coronary sinus, they'd have about a 47% of those patients would respond, with a 15% relative reduction in LV systolic volume. And in fact, 33% were super responders from all patients, and 5% of non-responders were super responders. So marked improvement in patients who were non-responders to prior CRT via the coronary sinus. The problem was with endocardial pacing, there's the risk of stroke or TIAs, and anticoagulation is critical. So there is a way to do endocardial pacing. This cartoon shows you. You implant a conventional pacemaker with, in the RV apex here, uses electricity to stimulate the RV apex. The pulse generator here, what happens is a pulse generator picks up the electrical activity from the RV pacing, okay? And what happens is this then results in this generating an ultrasound pulse that's transmitted to an implanted seed or LV endocardial electrode, and that results in electrical stimulation of the heart. So electricity is picked up by this antenna. This antenna transmits this electricity as an ultrasonic signal, which then results in electrical pulse here. How does this work? This is what it looks like. You deliver a receiver. This is about the size of the receiver in the LV endocardium. This is what it looks like in animals. So it's sticking out. You have to obviously anticoagulate the patient. This is the transmitter. This is the receiver. The patient has an RV lead here. The LV lead is inside here. Here's an RA lead. Patient has a CRT device, but no LV lead. And what you have is an RA pulse, an RV pulse. It results in an ultrasonic pulse, which goes to the LV, and then you have LV simulation. It has an anchor to anchor this mini electrode inside the LV. And what does this result in? So this is some early data on small numbers of patients, but you see patients have significant improvements in New York Heart Association functional class. You can see about a significant improvement there. And then look at the ejection fraction. Went from a mean of about 25% to a mean of about 35%. And you see in the majority of patients a substantial improvement in ejection fraction at 6-month follow-up. This is a composite global score in those patients who had LV endocardial pacing. This is a score that combines mortality, heart failure hospitalizations, New York Heart Association, and quality of life. These are CRT trials that were done clinically, published a number of years ago in the early 2000s. And this is this LV endocardial lead. Over 80% of patients were improved. Only about 12% of patients were unchanged, and less than 10% of patients got worse. So marked improvement in this composite global score. So that's one way to go, is LV endocardial pacing, with the understanding that many of these patients will need anticoagulation until that LV lead becomes endothelialized. So I want to remind you that when we do RV pacing, normal His-Purkinje activation of the ventricle, which is rapid and fast, is ignored, obviously, during RV pacing, right? That's why they develop cardiomyopathies, leads to synchrony and altered autonomic nervous system, and ultimately leads to a bunch of negative hemodynamic systems. With biventricular pacing, really it's the same thing. You completely ignore His-Purkinje activation. You have myocardial cell to myocardial cell activation, but you have it in both the RV and LV. You have better stroke volume, better cardiac output, less sympathetic nerve activation, but still not normal activation of the heart. It's really only with His bundle pacing or pacing of the conduction system do we get into the His-Purkinje system and activate the ventricle. And that's what I want to spend the rest of my time talking about. So first of all, a little bit of vocabulary. Selective His bundle pacing is illustrated in this figure. Selective His bundle pacing refers to activation of the ventricle solely through the His-Purkinje system, as reflected by an identical QRS and T wave that is similar to what the patient has in the underlying state. Yellow refers to an isoelectric period, which you can see in each lead of a 12-lead EKG. This isoelectric period represents activation and time of the specialized conduction system of the heart, typically about 40 to 60 milliseconds. Non-selective His bundle pacing, which is what we see in about 2/3 of patients, 2/3 of patients have conduction system pacing, has a pseudo delta wave. And this is because you not only get into the specialized conduction system, but you have local septal myocardial capture from the septal myocardium, near where the lead is, near where you begin to get activation of the His-Purkinje system. But it's much more complicated than that. Here's a patient who has a baseline left bundle branch block, okay? Here you see with His bundle pacing, again, you look at the stim to QRS interval, you have a QRS duration of 90 milliseconds. So you've completely normalized this left bundle. With His bundle pacing, you've normalized this left bundle. Hence, by the end of this lecture, you're going to stop calling left bundle branch block, and start calling it left bundle branch delay. It can't be blocked, right? Because you're pacing the His-Purkinje system. And it's gone. The left bundle's gone. QRS duration is 90 milliseconds. As you lower the voltage, you're still pacing the His-Purkinje system. You're still targeting the His-Purkinje system. But you've gone from a QRS duration of 90 milliseconds to, again, a wide QRS. Not quite as wide here. So you've gone from complete correction of the left bundle branch block delay to partial correction of the left bundle branch block delay. And here's another example of a patient. Now you have this patient where you have RV and His bundle capture. Again, you don't have any isoelectric interval here because you have this pseudo delta wave because you're capturing both the RV and His bundle. And then you go to pacing only the His bundle. And now you're pacing the right bundle only, again, through selectively pacing the His bundle. So you're pacing the conduction system, not the ventricular myocardium, but you're capturing the right bundle because the patient has a left bundle branch block. And now you're not capturing anything. And what does the patient have? They have a right bundle branch. So this patient has a right bundle branch block. You see you're capturing their right bundle here. Here you're capturing their His bundle only, but you're recruiting their right bundle. You're recruiting their right bundle. And here you're recruiting their right bundle, but you capture both the RV and the His. So you can have multiple complex configurations. Now, the bottom line is that from this elegant acute study in patients who had left bundle branch block, again, you have activation. Here's the patient with left bundle branch block. Their LV is, lateral LV is activated way out here, 180 milliseconds later, okay? And this is the patient, intrinsic unpaced QRS, base to apex, and here's left bundle branch block. Now look what happens with His bundle pacing. This is the RV, this is the LV. Base apex, RV conduction, pretty normal with left bundle branch block. Lateral left ventricle, way late. Here with His bundle pacing, really not that much difference in how the RV is activated. This is maybe a little bit earlier, but not that much difference in the RV. But look at what happens when you pace the conduction system and correct the left bundle. Now the LV is activated within 120 to 130 milliseconds, as opposed to 180. So we've gone from 180 milliseconds to 130 milliseconds. With bi-V pacing, you see the LV is activated early and the RV is activated early. Why is the RV activated early? Because you're pacing the right ventricle from right over here. Why is the LV activated early? Because you're pacing the LV here. But you're getting disordered ventricular activation. You're not completely normalizing it because now the late area of activation is not lateral, but septal and posterior. Well, that's nice. Let's see how that translates into systolic blood pressure. With bi-V pacing, the mean increase in systolic blood pressure is 6 millimeters of mercury. With His bundle pacing, it's about 12. So it's almost double the blood pressure increase. And if you look at the LV activation time, what LV activation time is, if you look at the left ventricle, EKG, you look at a 12-lead EKG, and you look at the peak of the R wave in the precordial leads, how long does it take till it peaks? And what you see with biventricular pacing, okay, the reduction in LV activation time, you only reduce it by about 16 or 17 milliseconds. But with His bundle pacing, you can reduce it by 40 or 45 milliseconds. And that difference in reduction in activation time with His bundle pacing or with bi-V pacing is proportional to the improvement in blood pressure, systolic blood pressure. Now, this is great, but how does this translate into clinical outcomes? Well, there's only one very bizarre clinical study that I have to share with you, but it is unique. And it's easy to remember because who the heck would ever do this sort of study? But it's pretty amazing. 2 medical centers, 45 minutes apart, both part of the Geisinger Medical Center. Both hospitals part of the Geisinger Medical Center. 2 groups of electrophysiologists, two electrophysiologists at one hospital, 4 or 5 at the other hospital. In one hospital, they do 100% RV apical pacing. In the other hospital, they attempt to do 100% His bundle pacing. So if you look at the primary outcome, randomized by whether you end up at hospital A, where they only do RV apical pacing, or hospital B, where they only do His bundle pacing. This is all comers, regardless of whether they have 6 sinus syndrome or heart block. What one sees is the primary outcome. composite outcome, death, heart failure, hospitalization, or upgrade to BiV pacing is less in patients who have hip bundle pacing compared to patients who have RV apical pacing. Statistically significant. All this difference is concentrated in patients who are 40% or greater RV pacing, as you'd expect. This was a small study comparing hip bundle pacing to BiV pacing, a crossover study, and basically it showed whether you do HIS or BiV, the EF is about the same, the improvement in heart failure is the same, improvement in quality of life is the same, improvement in 6-minute walk is the same. Small numbers of patients. I want to go through with you quickly in about 5 or 6 minutes some of our observations. So this is a case of a 72-year-old woman who was referred for a dual chamber pacemaker for symptomatic sinus node dysfunction. Please note her PR interval is about 280 milliseconds, okay? So given her anticipated high RV pacing burden, a hip bundle pacemaker was implanted. And you can see here, if you look very, very closely, you can see A pacing, you can see V pacing, PVC, AV pacing. We implanted this pacemaker. It was a difficult implant. Thresholds at implant were 0.7 volts. 1 month later, they were beautiful. 6 months, they had gone up to 4 volts. By 8 months, they were 4.5 volts. So clearly not so good. So patient came back. She was referred for a left bundle lead. And you can see her hip bundle lead. And now you can see where the left bundle lead is. You can see her HIS recording on her hip bundle lead. She studied HIS recording. And you can see a left bundle recording on the left bundle lead. The HIS to V is 48, left bundle to V is 22. Here's what her pacing looks like. Again, you can see QRS is really, really narrow. These are all pace beats. You can see a short stem to QRS, the LB to V. And look at her thresholds. This is the difference. Thresholds at 6 months are 0.7 volts at 0.4 milliseconds, nothing special. At 9 months, they're 1 volt at 0.4 milliseconds. Where do these leads go? So let's talk a little bit about anatomy. Here's an example of septal leaflet of tricuspid valve. This is the patient who had a hip bundle lead. They ended up with cancer and then dying from a car accident. And you can see in this paper that we are pacing the conduction system, as you can see here, from above the septal leaflet of tricuspid valve. Here's the gross anatomy. You can see the septal leaflet of tricuspid valve here. You can see the hip bundle lead here. You can see transilluminated the membranous, the AV membranous septum here. Here's a CT scan of one of our patients we published a couple of years ago. And with 3-dimensional reconstruction, you can see the lead, both on CT scan and on echo, is right above the tricuspid valve. Here's the RA, here's the RV, here's the tricuspid valve, here's the hip bundle lead. Now, I don't have time to go into detail, but there are 2 papers I'd love you to take a look at. These 2 papers, this paper and the next paper, bring you back to those horrible days of first year of medical school, but they look at the anatomy. So the important anatomy is shown here. This is a heart dissection that looks at the spatial relationship of the different heart chambers. And I want you to focus on the membranous septum, which you can see in C and D. There's a white arrow pointed to. I want you to note the close relationship of the membranous septum to the septal leaflet of the tricuspid valve, because about half of the patients who have hip bundle leads have the leads implanted right here, right above the septal leaflet of the tricuspid valve, and the other half of the patients have the hip bundle lead implanted below the septal leaflet of the tricuspid valve. Again, the membranous septum is shown at the white arrow, and in this blue dotted line is the membranous septum. And then you can see with the LV opened up where the left bundle is. And here you can see opened up from the tricuspid valve hinge point, the conduction system before it starts to bifurcate. Now, this is a study which was just published in the last month or so, and it's pretty amazing. They took multiple slices of the conduction system in 40 human cadavers. And the take-home message, because I don't have time to go through every one of these, but I will point. So here's the common fibrous body. These are Mason trichome stains. Red refers to ventricular myocardium, blue connective tissue. Here's the central fibrous body, or the His bundle. And you can see that the His bundle is surrounded by a sheath of connective tissue. And you can see then the bundle, the branching bundle, which ends on the ventricular summit of the muscular septum here, going to the right bundle here and the left bundle here. And what I want to show you is, if you look at this, you'll see the tremendous variation in where the compact AV node is relative to the penetrating bundle of His, the amount of connective tissue. Here you see the penetrating bundle of His, and you can see from the endocardium there's relatively little connective tissue, but here there's a lot of connective tissue. And I will skip this slide and go into this slide. The amazing thing about the left bundle, this is from Tawara's original description, but the image shows the extensive arborization of the left bundle system. You can see the left anterior fascicle, you can see the left septal fascicle, and the left posterior fascicle, but then you see this extensive serpiginous network of the conduction system. And here you can see these rich intercommunications as the left bundle bifurcates into a small to the base of the anterior papillary muscle, this network of subendocardial sort of Purkinje fibers here bifurcating, going towards the posterior papillary muscle. Again, a little bit thicker, again, network of Purkinje fibers. And you can see it's this network of fibers in the septum. That is what we actually pace when we pace the left bundle. But our textbooks are wrong because they characterize the main fiber and they fail to point out the importance of these rich interconnections. This is from a recently published animal study. You see where the His bundle lead is in a canine model, and you see where the left bundle lead is, okay? And here you see the left bundle lead on the right side of the septum, and you can see this fine network of the conduction system here. It makes you appreciate the multiple chances we have to pace the heart when you're going for this network. This is just recently published online in JACC case reports. We're trying to pace the left bundle. I want you to look at this. Here's the left bundle surrounded by connective tissue in one cadaver specimen. Look at the left bundle now in a different cadaver specimen. It's 3 times thicker. And then here in another cadaver specimen, it's 4 or 5 times thicker. A lot of connective tissue, but a thick myocardium that we want. So there's tremendous variation in the amount of muscle, in the amount of connective tissue or fat surrounding that muscle when you go from patient to patient, explaining why some people are easier to match. Now, this is an amazing paper published in Nature. They took these mini pigs and did CT scans of these pigs, and then they highlighted their conduction system. And you can see the distal His. You can pace the distal His. You can pace the left bundle here. You can pace the left bundle here. You can pace the left bundle here. And you can see the rich conduction system. Here's the right coronary cusp and non-coronary cusp. Here's the AV conduction system branching into the left conduction system, the right bundle branch block. But you can see all the options you have to pace the left bundle. I want to end with this really beautiful, beautiful study. It's one of the best studies I've seen. This is why we can pace left bundle branch delay, because the block or delay is in the His bundle, and about half of the patients. And when their site of delay is in the proximal to mid-His, in the His bundle itself, you pace the His bundle, you can correct half of those patients. And another 20% of patients, delays in the left bundle branch block. If you pace the left bundle, then you can correct almost 70% of patients. In about a third of patients, the QRS delay is due to intact but distal conduction delay. And in those patients, we're never going to be able to correct their left bundle branch delay. This is due to distal and diffuse conduction system disease. So here we go. We can pace here, we can pace here, we can pace the His bundle and correct some left bundle. We can pace here, here, here. These are all the different places. We can pace the conduction system in patients who have left bundle branch block or heart block for that matter, and normalize their QRS. So in conclusion, His bundle is surrounded by connective tissue from the central fibrous body, and thus there's really no myocardial tissue to at least easily pace. Understanding the anatomy is key to making advances in this field. Routine permanent cardiac conduction system pacing is feasible and appears to be superior to RV pacing. Conduction system pacing can be successfully performed in patients with AV nodal block, intra-His AV block, right bundle branch block, and left bundle branch block. Never again use the term right or left bundle branch block. It's not bundle branch block. It's bundle branch delay, because we can correct the vast majority of these patients. His bundle pacing can have a significant impact in patients with heart failure. We've seen patients like this who we have paced, and it's been quite dramatic in how much better they've gotten. Better advances in lead technology are being made. That will be critical. And the ultimate goal is to be able to pace the conduction system leadlessly. And that is really the future of physiologic pacing. And with that, I'll stop and be glad to answer any questions. Thank you.
Hi, this is Fadi Akar. How are you? That was a wonderful, wonderful talk. I was wondering about the pacing thresholds. So surely with the His bundle, they must be a little bit higher than conventional approaches. And so I was wondering what the methodologies or the work that's being done to try to optimize that and try to reduce thresholds for long-term use.
So I think there's not a lot of work being done in that area, because I think the real limitation is you're pacing the His bundle through some amount of connective tissue. And there must be some sort of fibrotic response that occurs in about 15% of patients that leaves those patients with very high pacing thresholds. I'm not sure that a lot of effort is being made in that area. Most of the effort is being made in developing newer leads that can reliably and successfully pace the conduction system at somewhat more distal sites, like below the tricuspid valve, in the high left bundle or somewhere lower in the left bundle, because I think reliability is critical, and most people are unwilling to accept these are steroid-eluting leads, accept a 15, well, they'd have to develop some way. The leads we're using are not steroid-eluting leads, and the leads we're using are primarily older technology leads. But I think most of the research is focusing on sheaths to deliver the leads, because you have to deliver the leads to the septum, I think. And delivering them to patients who have cardiomyopathy can be challenging, as you know from doing CRT. So it's really trying to make this therapy so we can deliver it to more patients, as opposed to make it so the pacing thresholds are going to be better, because that's not really a problem when you're not pacing the His bundle, when you're pacing more distal sites.
Ken, this is Rachel Lampert. I'm sorry not to see you in person. Am I coming through?
Yes, Rachel.
Hi. So a question that continues to puzzle me about the His bundle pacing. Conduction system disease is so often progressive, and how can we feel comfortable that the conduction we're getting today is still going to be there in 5 years?
So that question comes up a lot.
Yeah.
And I can tell you, we published a paper, so we've been doing this now for, I think, about 5, 6, 7 years. And the folks at Geisinger have been doing it for a decade or longer. We published a joint paper of patients, with long-term follow-up. And they've had some patients, obviously only, less than 10 years, who, because of the higher thresholds, have come back to generator change, because thresholds are 1.5 or 2 volts. And patients who have block. And it doesn't appear, it seems that if people have block in the AV node, that's where they always have block. If they have block, intra-His block, it seems like they always have intra-His block. And if they have block, in the proximal left bundle, it looks like that's what they have. I don't have 10 or 15 years of follow-up, so I can't answer your question. That's always been a concern, but I actually think it's a concern because we think of block as fibrosis and block, and I don't think it really is that. I think it's just delay. I don't have any other, it has to be delay because, how can you take somebody with right bundle branch block, put a lead in, and all of a sudden they're conducting on their right bundle? So I just think it's delay. I think, and for whatever reason, and maybe I'll be wrong, it doesn't appear to progress, at least, based on what we've seen so far. But you're sort of right. You can be a little bit skeptical until these leads have been in, or we follow patients for 10 or 15 years.
Thank you.
Dr. Ellenbogen, it's Dan Friedman. Thank you for a terrific talk. There's obviously a lot of questions about ease of implantation and threshold issues that Rachel touched on briefly with His bundle pacing. If you could look into sort of your crystal ball, do you think that left bundle area pacing is going to take over His bundle pacing because of a lot of those issues?
So we've been doing this for a long time, and we do these things where we have people come. I think because pacing is easy to do, that unless I think for conduction system pacing to work, it has to be relatively easy to do. And even though we've done 400, consecutive patients, relatively consecutive patients with conduction system pacing for His bundle pacing, our experience has been that it's not that often that easy to do, that you really have to work at it. And sometimes you have to work at it for 10 or 15 minutes. And even though you can end up with a QRS of 90 milliseconds, most doctors are not willing to spend that sort of time to do something better that they can do easily. I don't know why that is, but that's true. And sometimes you really work at these leads, and then you come back 6 months later and the thresholds are high. I won't say that's true for the entire field, but we have completely abandoned putting His bundle leads in for left bundle leads. And everyone in our group can do it and do it well, and and can do it in 5 or 10 minutes, like 95% of the time. So, and the great thing about putting a lead in the left bundle or putting it in the septum is that if a patient has chest pain after the procedure, it's the atrial lead because it's buried in the septum. And so then it has to be the atrial lead that's microperf. So, but it is a lot easier to do. And we have just decided that's all we're going to do and we started doing that in January of last year. And we've done 250, 260 almost consecutive cases. I mean, if it's a 92-year-old patient, we may not try very long, but 95% of our implants are left bundle. So.
Dr. Ellenbogen, thank you for a wonderful talk. This is Nimrod Levi. I wanted to ask you a question about the retrograde conduction from the left bundle to the right bundle. When you're pacing selectively only the left bundle, if you have an intra-His conduction delay or block, would you have a retrograde conduction to the right bundle? Or you're basically pacing only the left bundle and activating the ventricle via the left bundle?
We can, so that's really good. We can do sort of our version of parahysteine pacing. So sometimes you see retrograde left bundles. Yes, you can conduct retrograde. So yes, you can see all sorts of conduction patterns that are quite fascinating. You can see retrograde left bundles. You can conduct to the atrium through retrograde right bundle. And you can see the long BA times because of that.
No, but the question is, if you pace the left bundle, let's say you're not pacing the His and you're pacing off the left bundle because you're suspecting that you're going to have a delay in the His. Now, if you're pacing the left bundle alone, will you get on the EKG only right bundle branch block, or you get a neurocurious complex because you get retrograde conduction to the right bundle from the left bundle pacing? When you're pacing the His, you're going to conduct through both bundles simultaneously. But when you have an intra-Hissian block, would you conduct also and activate the right bundle, or selectively only the left bundle?
No, you basically see an RSR prime that's typically about 110 to 130 milliseconds is what you see when you pace the left bundle. And we actually look for that when we pay. That's one of the, so there are a number of things we look for. If they don't have left bundle branch block, you can record a left bundle, you can record the left bundle potential. But if they have left bundle branch block, you can't. Then you have to go by other ways. How do you know you're pacing the left bundle? So one of the ways you know you're pacing the left bundle is you look at the stim to V. You want to make sure you're pacing the conduction system. The other way you can tell is you want to make sure your stim to LV activation time is the same, regardless of whether you're pacing at high output or low output. And then you want to look at V1, and you'll almost always see an RSR prime or QR prime in patients if you're really capturing their left bundle. Does that answer your question?
Yes, I was just wondering if also if you have a conduction delay in the right bundle, if it makes sense to in some patients to put sort of like a His bundle to pace the right bundle and a lead to pace only the left bundle to get a neurocurious, or it's enough just to pace the left bundle in these patients.
Yeah, well, so general, I mean, I'm not sure, yeah, I see what you're saying. I don't know that we've actually looked at patients who both have, you know, who also have a right bundle branch block. So we're actually going through all the EKGs on all our patients, trying to sort of categorize the QRS morphologies and axis. So maybe I'll have a better answer for you, but I haven't specifically looked at patients who also have right bundle branch block delay, what their QRS morphology looks like, whether it looks narrow or less narrow. A fair question.
Thank you.
Well, if there's no other questions, thank you very much, Dr. Ellenbogen, for spending the morning with us, albeit remotely. It was an absolutely fantastic talk, and hopefully we'll have the opportunity to actually physically bring it to campus in the coming months whenever it's considered feasible. So thank you very much.
Sounds great. Look forward to it. Bye-bye.